You are listening to Science Coast with Mallory Havens and
Chris White.
And today our guests are
Daisy Sherry.
Tina Bobo.
Welcome back.
I would like to talk more about the nursing profession and how it's changed over the past 20 years or so, because I've read so much about what happened during the pandemic, which is just a couple of years ago, and so I would love to hear more from your perspective about how nursing has changed and what happened during the pandemic.
So I'll start. Okay. So when I started as a nurse, it was very popular. Nursing kind of goes in cycles, right? It's very popular, and then it's unpopular, and it's popular, and then it's unpopular. So when I started, it was a very popular career choice. It was very looked favorable in the public's eye. And so similarly, the job market was very favorable. And so I went into it in a very kind of happy, glass half full kind of an environment. And so I enjoyed my first few years of nursing and critical care, intensive care very much, very satisfying. I loved seeing the patients. They came in to me very ill out of the OR, a fresh heart, out of the, having open heart surgery, and just helping them convalesce and seeing them wake up, extubated, and moving on, feeling hopefully better and moving on with the rest of their life in a healthy way.
How many patients would you have in the ICU?
Back then it was 1. If there was a fresh heart, it was 1-to-1. And then once that person recovered to a more stable state, then you maxed out at 2.
Oh, that's great.
It was very manageable. I felt like I gave really, really attentive care to my patients. So I was really fulfilled in my role. But then, years went on and just the pressure, there was a lot of pressure on nurses as the years went on to move patients, get them out faster, move on to the next one, that kind of an attitude. And even, as my role evolved and I got training to be a nurse practitioner, my clinic schedule then became, I moved from having, 20 minutes with a patient, then we were squeezed to, okay, here you can have 10 minutes with a patient in the clinic. And so that was very dissatisfying for me. I can't, I can barely, have breakfast and a cup of coffee in 10 minutes, and you want me to take care of a patient's illness and make sure you address all of the things they need that, you haven't seen them in 6 months. I'm not a miracle worker, and so I walked away from those encounters very dissatisfied.
Dr. Bobo, did you have similar experiences?
Definitely. So my first job was in a Children's National Medical Center in Washington, D.C., in the pediatric ICU. That was my first job. And I was saying that we would have one child, one-to-one care. Everything was pristine and perfect. Very comprehensive type care provided to those patients. As I decided to go back to school to get my master's degree, I went next door to the Washington Hospital Center, and just going from peds to adults was just I felt like I had landed on a different planet, but I wanted to focus on trauma critical care, so I had to do adults, and we started then. Rapid extubation was kind of like the new thing to get the post-open heart patients off the ventilators quickly and maybe to a general floor instead of critical care. Again, cost motivated, of course.
Right.
And I'm sure, better for the patient, right? Let's get them well as quickly as possible. And that CVOR recovery unit was very stressful. Pushing the patient. I had one patient by myself, recovering that patient alone. Like today at Edward, for example, there will be 6 nurses come to the bedside to greet a patient right out of the CVOR. If you think about how many people take care of a patient in the operating room, and then you just try to get one nurse to hang like multiple blood products and pressor medications to keep them stable. There's a lot of pressure. So the change from a financial standpoint, it felt like from going from a single patient providing comprehensive, safe care to taking care of a patient that was very complex with one nurse and not a lot of support was difficult, for sure.
So it's really trying to squeeze more productivity out of every individual, nurse that's in the system, and that's leading to burnout.
Yes.
Because at some point you can't ask people to keep doing more and more. At some point they basically say, "Okay, I'm done. I'm not going to do this anymore." Is that what happened during the pandemic?
I believe so. We saw, the health system was not perfect to begin with, and then the pandemic just shed light on where the cracks were in the foundation, and so things were breaking. And a part of that was really testing the frontline folks or the nurses. Are they up for this kind of situation, this kind of stress, this really kind of risk, not only to themselves, but for their families that they go home to. And so we saw people leave the profession, unfortunately. For me, it was pre-pandemic, but it was very much that I left because I could not keep up with the expectations on me and deliver the care good quality care that I wanted to give to patients, and know that they were safe and they were in full understanding of what they need to do to be well and stay well. So yeah, that's what kind of pushed me to leave and go in another direction.
During the pandemic too, you would see just the PPE shortage and like the fear of what you're being exposed to. Like, I think if it was an Ebola outbreak or something, how much worse that would have been. I mean, not that it wasn't terrible, but it's scary that you have to put yourself out when you're working on patients being exposed to pathogens without proper protection. It's got to be scary in the ER just on a regular day if you're not masking.
Especially if you have kids at home.
Right.
Yes. So we were on the front line. We didn't know very much about this virus at all. And I remember we had two whole entire units that were negative pressure units. So we moved patients that needed to be in those units to other areas so that we could utilize that technology to try to keep everyone safer. There were like police tape type yellowed lines off, where we would like segregate off the patients, and it was very scary for us, right? And so with the shortage of equipment and supplies and PPE, it wasn't just equipment, supplies, and PPE, it was medication shortages, everything pressed in the system and all of us to change the way we do things. We would have to wear the same N95 mask for an entire shift. And there was no, scientific basis that was safe, that it was the way it was intended. I mean, these are single-use masks that we would have to go into a critically ill patient's room and suction them through their endotracheal tube where, aerosolized particles of COVID, for example, which we know it was aerosolized, and using a mask that maybe wasn't effective. I remember finally getting the respirators, that we could wear that were more protective. But it was such a challenge on the whole system. The stress of not knowing started, in the very beginning, put everyone on edge. And then not on top of that, not having the supplies and the support that you needed and understaffing and all of that made it really challenging. Providers wouldn't go into patient rooms, so they would ask the nurse, have you listened to their lung sounds? I remember a cardiologist sidelining me, asking me all this information about a patient because he didn't want to go in the patient's room.
That's scary.
This is going to sound flippant, but I base listening to what you're saying is COVID was not a hoax.
No, it was not.
Because I think that there are still some people out there who basically are saying that it was overblown, it wasn't such a big deal. Why are people making, why do we have to do this? Why do we have to do that? But I mean, listening to your firsthand account of your own personal experiences, it's like, wow, that sounds really scary.
We saw the patients, I worked more specifically in the ICU, in the medical ICU, where we saw most of the patients because sedating the patients was so difficult. A lot of the medicines we used are lipophilic medications, and so we had patients like on ECMO, which is like a heart-lung bypass machine, and those medications would not work on those patients because of the filtration system for that therapy. So we had to come up with other medications, and they were intubated sick for so long they became tolerant to the medicines, and there were shortages of the medications. But just seeing the death, we saw so much more death than we had ever seen in our careers as nurses all at once. That was what was devastating and scary.
Right.
Well, if I could jump in and kind of bring some light to, instead of it being so negative and down, which it was. I mean, there were a lot of deaths involved, but for me, I was volunteering at a free clinic when the pandemic hit, and so this was an outpatient center, and so all the patients we see did not have, they don't have health insurance, and so they really don't have anywhere else to go. We had to keep the doors open. And so we found our creativity came out during the pandemic. We moved our clinic outside. We put up tents, and we were doing vital signs outside. We, had to space everyone out into the hallway, into the church where we were adjacent to. And so we just, did our best with what we were learning, and as we learned it, adapted again. And so I'm really proud of the staff and the leadership there for really adapting. And then we also were open to moving to telehealth. And so we moved to technology to kind of help us continue to provide health care to those folks without health insurance. And so everyone has a cell phone, and we were able to communicate with them, check on their blood sugars, titrate insulin. Specifically, we were very worried about our diabetic patients. And so telehealth was new for us, but, we made it work.
So I think that telehealth is a great way to think about technology advance, and the fact that, since you first got your degree and started practicing nursing, there's been just this continuous implementation of new technologies. How do you keep up with all of the new technologies?
Oh gosh, that's a great question. You learn as much as you can. You keep in touch with the clinical setting to see what's new, what's needed, and you continue to learn. It's really a great example of you have to be a lifelong learner if you want to be an effective healthcare provider, because it's continually changing and hopefully for the better.
Does nursing have continuing education you have to do to keep your license?
Why, yes, they do.
Well, it seems like it's built in. Yeah, I assumed that was probably true because most professions where you're licensed by the state, you have to do that. But
so what are the requirements to maintain your license?
I think it's 20 CEs per year that you're required to have to maintain your license. And it's kind of an honor system where it's audited, right? So you have to maintain your own records. And if you were audited, then you need to show those records. Otherwise, you renew your license every year and attest basically that you have 20 CEs.
And it's per license. So if you have multiple licenses.
So what other kinds of, so are you saying that you have like an RN and nurse practitioner license, like multiple, or do you let the RN one lapse if you have the higher license?
No, you have to keep both.
Oh, so now you have to do at least 40 hours.
It is. It's great math.
Do we offer,
Thank you.
Do we offer continuing education at Lewis?
Yes, we do. We are an approved provider to offer continuing education. And so we do offer at least every semester.
What do you see when the nurses are coming in for the continuing education? What are they telling you?
The nurses attending the CEs?
Yes.
Oh, I think that they're very happy to attend. We offer them free of charge. And so that's kind of rare. Usually there's a price tag. You have to pay for those units. And it's nice that they can come to us to learn. And, that's kind of our wheelhouse, right? We teach. And so it's just a nice fit.
In that way, too, you kind of have a great door, not that you don't anyway, but a great door into what's happening in clinics maybe that we don't have students going directly into. So nurses coming from hospital systems or whatever that Lewis isn't affiliated with.
So technology is advancing. And of course, the financial aspects are evolving in time. What other changes have you witnessed over the past 20 years? Medications, have they changed dramatically as well?
For sure. Definitely changes in medications. There's so many different, so there's like a generic class of medications, and then there's so many different brands of each medications. The cost of the medications often are exorbitant, and many times patients can't even afford to get their basic medications. They come to the hospital, which of course then impacts the cost of care, right? So when you have a patient who's non-compliant because they can't afford their medications, then they come to the hospital, then that costs more money, right? If we could have provided them somehow, assisted with their getting access to the medications, then the cost of that hospital admission could have been avoided.
Right. People who end up having to use the ER as their primary care is not great for the system.
If there was one thing that you wanted to leave the audience with in regards to nursing, what would you like people to know about the nursing profession?
I would say that, nursing is changed. You had mentioned the word evolution earlier of nursing. And so I think over the decades that nurses have become more positive in the public eye. Very much started out as kind of more of a subservient, primarily women, kind of a career choice. And so I think nowadays it's much different, right? We're a diverse population when we are seen as independent and advocates for our patients. And so there's also lots of opportunity with nursing. And so, you can move to different fields. That's a very attractive part. Other people that are prepared at, the bachelor's level can't really claim that, right, that they could move from one topic area or one specialization to another. Say, you have a mother-baby kind of a patient and you wanted to move to a critical care kind of a setting, you could easily do that as a nurse. And so the variety keeps things exciting and fresh, as well as the continuing to learn, I think, are really positive about the career choice.
Dr. Bobo, what would you like to add?
I think the evolution of technology in healthcare is attractive too, especially to the younger generation. They enjoy that kind of, I certainly do too, I have to say, that aspect of things. But the reality of the situation is, in the end, you're caring for another human being. So that that kind of fulfillment with being able to have such an impact on another human being's life is still a big probably draw and positive about the profession.
The views, thoughts, and opinions expressed are the speaker's own and do not represent the views, thoughts, and opinions of Lewis University. The material and information presented here is for general information purposes only. The Lewis University name and all forms and abbreviations are the property of its owner, and its use does not imply endorsement of or opposition to any specific organization, product, or service. This podcast was produced in the WLRA podcast studios at Lewis University. Visit lewisu.edu for more information about Lewis University. You've been listening to Science Coast with Mallory Havens and
Chris White.
And our guests,
Daisy Sherry
and Tina Bobo.
Thanks. Bye.
See you next time.